right, so let's begin. My name is Candice Coughlin, and I'm going to be your host today. I am the Education and Outreach Coordinator here at UHN Center for Living Donation, and I am also a patient. I was a crash start onto dialysis at the age of 24. I did hemodialysis for about 8 months, and then I went to at-home peritoneal dialysis for another 8 months. And all through that time, my mother was being worked up to be my living donor. And we were able to have our transplant on September 9th, 2009. So 9 is now my favorite number. And we've been doing great ever since. My husband and I also welcomed our first child, a healthy little baby girl, in February of last year. So lots of firsts for us post-transplant. We were able to get married and purchase a home. So it's really my pleasure to be part of this first 100 days post-kidney transplant webinar and to talk about living donation because it's been such an incredible gift to my life. Just to let everybody know, this session is going to be recorded. And if you have any questions throughout this webinar, feel free to type them in our chat, and we will have a Q&A at the end of this session that will go through those questions as well as any that were submitted through the Eventbrite link. And if you haven't already, please mute yourself just so that if we have any background noise, we won't be bothered by that. And so it's my pleasure to introduce you to our two speakers today. Our first speaker is Theresa McKnight. She's a registered nurse and primary care nurse practitioner with over 30 years experience working in renal transplantation and 11 years in long-term care. Her professional interests lie in immune-related disease, health promotion and disease prevention in immunocompromised and frail elderly populations, and in palliative end-of-life care. She's interested in the use of cannabis as an option for pain and symptom management for various disorders and has completed the Cannabis Educator Certificate Program. Theresa's main focus is providing long-term follow-up care to renal transplant patients at the Ajmera Transplant Centre. Welcome, Theresa. And our second guest is Sheena Branigan. She is the fourth of 5 siblings fortunate enough to have received a kidney transplant from her sister-in-law at the end of October 2021. So Sheena today will share her kidney journey and post-transplant experience so far. Welcome, Sheena. So let's start the webinar. First, let's chat with Theresa. We would love to get your insights with all of your amazing experience on the care pathway that happens for patients with our 100 days post-transplant. So wondering if you could speak a little bit about what happens in the hospital for transplant patients.
I can. So welcome to everyone at the webinar. I want to start off by saying, first of all, I have the best nursing job ever. So I have the luxury of looking after people, caring for patients over the long term. So it's very unique, and I'm not sure anywhere in any other area of nursing where we have this long-term follow-up. So just to give you some idea, some of the patients that I follow have known me since I left nursing school. So that's well over 30 years. And so it's wonderful because it's a very unique and trusting relationship. So I very much enjoy it. Now, coming into hospital for transplant is always very exciting. And those first 100 days are both anxiety provoking and stressful and exciting at the same time. So when patients first come in for their surgery, believe it or not, we start preparing for discharge at day 1. So unbeknownst to some patients, we are already planning for you to go home. So, and we do that with a whole host of members of the care team, but most importantly, the primary person in your care team is you. So the patient and the their caregiver is number one as part of the team. And then we have the nurses on the inpatient unit, nurse practitioners, physicians, fellows, physiotherapists, dietitian, pharmacists, social work. All of us work together in order to create the best experience for you and have you go home safely. So initially it starts where, you've had surgery and it's the, usual, for lack of a better word, pathway that you would follow after waking up from an anesthetic. So we want to make sure that you're awake, alert, that your vital signs are stable, that you're at a point where you can take in fluids and some diet, where you're starting to ambulate. Some of the things that you will wake up and find is that you have an incision. So part of your inpatient stay will be monitoring that incision to make sure there's no leakage, that it's healing well. Patients will have a Foley catheter, which is also quite normal. That stays in and monitors the urine output, which is always very exciting. And that stays in for anywhere from 3 to 5 days. Patients who are previously on hemodialysis will still have their subclavian line or their fistula, and often that line is removed before you go home. Patients on peritoneal dialysis, depending on the type of transplant. So for most living donor transplants, we would take out the peritoneal catheter at the time of the surgery. But other patients that have perhaps were on the waiting list or for other unique reasons, the peritoneal catheter may stay in and we remove that after. There's some times that patients will require dialysis for a short time after the transplant. My advice is don't be discouraged. This is often quite normal. Every situation is different. But our goal is that you go home off dialysis with a successful functioning transplant. The other piece of equipment that you're going to go home with is called a stent. And one of the things that causes patients to have some anxiety, because you have to wait 4 weeks to have that removed, and you know that appointment is upcoming. But the stent is a small, tiny tube that sits in the ureter, which is the small tube that goes from the kidney to the bladder. And the main purpose of the stent is to make sure that the ureter remains open while the healing process is taking place and that there's no backflow of urine back up into the kidney. So it really ensures that there's free flowing urine.
Amazing. And I know a lot of us transplant patients were told that urine is also called liquid gold. So,
absolutely.
And we talk a lot about pee during our stay as a transplant patient, which is amazing.
Yeah.
So I know you talked a little bit about getting excited for discharge day and
Yes.
Going home. So what actually happens on that discharge day? What would we look forward to?
So that's often very overwhelming. So should you feel overwhelmed, I would be surprised if patients were not overwhelmed. So a lot of things are happening when you think about it in a short time. So most patients will go home between 5 and 7 days. And there's a lot that we have to do in that short period, because for the first couple of days, for the first 48 hours, you probably are not at a point where you're receptive to having the teaching done. So the medications are a huge part of your discharge planning. They're new. They cause some side effects, which we'll talk about when we talk about after the discharge. And I can't emphasize enough that the most important task that patients have and having a contact person or caregiver with them is learning those medications, what they are, why you're taking them, the dose that you're to take, common side effects you may or may not experience, and that continues, and we talk about that often in the clinic. Knowing what they look like and when to take them. That's probably the most the most important task that you have after the transplant. The other thing we do is ask you to monitor blood pressure. We ask you to monitor temperature. So we go through that. Those are things that you're going to have to be prepared to do at home. Weigh yourself. So we encourage, while you're in, if somebody is able to ensure that you have a blood pressure cuff, a thermometer, a scale at home. We encourage patients to make sure that they have a contact with a pharmacy. So initially, we encourage patients to use the transplant pharmacy, where your prescriptions will go initially. And then if you have a relationship with a neighborhood pharmacy, that's fine. But again, we stress that you use one pharmacy only, so that there's no errors in your medications and the doses. We would put in place home care if there were needs for home care. And again, that's very individual. So some patients may have an issue with their incision where there's some leakage and they require dressing changes at home. All of that will be assessed when you're in. Physiotherapy will see you prior to going home to make sure that you are able to do stairs, that you're ambulating, that you're not dizzy or lightheaded, that you're not at risk for falls. The dietitian will see you because you're able to, obviously we encourage healthy eating, but it's very exciting to be able to not have the protein restrictions or potassium restrictions or fluid restrictions. So all of that will be reviewed with you prior to going home. And again, that's individual. Everybody will have somewhat different instructions. We do encourage people to have at least 2 liters of fluid a day unless told otherwise. There may be other situations where somebody is going home with a Foley catheter in. Now, most times it's removed, but on the odd occasion that you're going home with a tube that we were not planning for initially when you first came in, then we'll make sure that you have all the instructions in order to care for that.
Amazing. So you talked a little bit about medication, and I know that is a big part of a transplant patient's life and journey, both leaving the hospital with all of our information that we're given, and then, of course, for most of us, for the rest of our lives, how to get used to those meds. And so can you talk a little bit about what that medication regime looks like generically for most patients and kind of what to expect with your medications?
Yes. So most patients will be on 3 anti-rejection medications, and they may differ from patient to patient. But we do have a standard protocol where I will use an example. Someone might be on Advograph, for example, which is a once-a-day medication. But you take it in the morning, you take it always after your blood work is done. In the hospital, we tend to give medication at certain times. I always encourage patients that once they're going home to not be on hospital time. So I always stress that you need to get back to a situation that works for you. So if they were giving it to you at 6 and 6 in the hospital and it doesn't work and you want to take it at 9 and 9, then that's what you should do for twice a day medication. So Advograph, for example, is once a day. Most patients are on Myfortic. You may or may not be, but I'm using that as a typical patient example, which is a twice a day drug, And then prednisone is a once a day medication. So normally the medications are at higher doses in hospital, and we have to taper those or adjust those depending on levels, on side effects, on the time of the creatinine. Often on the creatinine level, we make dose adjustments. So everybody's medication is different, and we often see people in the waiting room, and I know from talking to patients that it's always good to compare doses, and well, I'm on Myfortic and why aren't you on Myfortic? But everybody's immune system is different, and we're all individuals. So although we have a standard protocol, we sometimes have to make adjustments according to the patient's own profile. The other medication that patients are often on is an antiviral medication called valganciclovir. And I don't want to take up too much time talking about it, but I'm happy to answer questions. But the reason for the valganciclovir giving this antiviral medication is because we do multiple blood tests before patients are coming into hospital and at the time of the admission. And one of those viral tests is called CMV, or cytomegalovirus. It's a virus that typically patients are exposed to by the time they reach adulthood, but we measure a titer, so we know that a patient is either positive or negative. Most patients are positive by the time they're adults. It's not a bad thing to be positive. This virus typically causes flu-like symptoms or cold symptoms. When you're young and exposed, you would not even know that you're exposed to CMV virus, that's the virus that caused your respiratory infection. However, and typically it's not an important issue until you're coming in to have a transplant and we're suppressing your immune system. So we want to know what that titer result is, because if you are positive, for example, or negative, for example, and your donor is positive, then we are essentially giving you that virus or exposing you to that virus. And we would give you an antiviral medication for 6 months, which is valganciclovir or Valsite. The other situation is if you're positive and your donor is positive, we would still give it to you, but only for 3 months.
Okay.
So nothing is ever 100%, as we know in life, but we give it to you because that's the highest period. That's the period of time where your medications are normally at the highest dose, the anti-rejection medication, and you're more susceptible to getting the virus. So we give it to you for 3 months, and then we stop it and we monitor as needed.
That's great.
The other medications that patients will frequently be on, and again, it will differ, but I bring them up because it may or may not have, you may or may not have blood pressure medications that are required that, if you required blood pressure medications pre-transplant, quite likely you're going to need medications post-transplant. We give you an antibiotic called Septra. All patients are taking Septra. The reason for the Septra 3 times a week is it prevents a lung infection called pneumocystis, which patients who have compromised immune systems are susceptible to. That's a lifelong medication. It's a common sulfa medication that's often used to treat urinary tract infections, but we give it to you at a low dose where it's not really a high enough dose to treat a urinary tract infection. However, it is at the proper dose to prevent pneumocystis. And then, of course, patients who have diabetes will continue on diabetes medication, sometimes at higher doses, which often makes it very difficult for patients who are diabetic and used to having total control over their diabetes. And then all of a sudden we give you Advograph and we give you prednisone, and all of those things contribute to your blood sugar being elevated. Mm-hmm. And so that's always a source of frustration, I know, in patients who are diabetic, because they say, I don't understand. I always managed my diabetes, and now all of a sudden, like, what's happened? Right. So that's quite common as well.
Okay. That's amazing. A lot of information. I know medication is often one of the big questions that we have post-transplant. I have been transplanted for 14 years, and all 14 years I've used my phone with 3 alarms, and I still use my phone to help me take my medication. So thinking about, overall health as a newly transplanted patient, what can we do to, stay healthy and safe in regards to physically? So, exercise and diet, our mental health, and then also newly added to our mix is COVID as well. So how do we manage the new world that we're moving into as a transplant patient?
Yes, so I'll talk about COVID first because I know that that's always on the minds of patients. You know, we encourage patients to have 4 vaccines. Some patients coming in for transplant will already have 1, 2, or hopefully 3 vaccines. The important takeaway from my message is that you cannot, and because we're talking about the first 100 days, we do not want patients to have vaccines in the first 3 months of transplant, not because it's dangerous, but because they may not be as effective. So, and that's all vaccines, whether it's the COVID vaccine, flu vaccine, some of the pneumonia vaccines like Pneumovax. So we want you to wait 3 months. That's why it's preferable when patients, especially during the pandemic, have had some vaccine for COVID before they come in, but that can be discussed individually with your care team after. We are encouraging and strongly recommending that patients follow all public health guidelines for COVID. So, and this goes really for any virus. If you know when you go home that somebody's ill, I would avoid seeing them for now. You can see them when they're better. We encourage patients to continue to mask, and especially having people in your home that may be unvaccinated, I would recommend continuing to mask. We recommend that patients exercise, and this is always a discussion in clinic because patients are tired when they go home. They're just tired. And I think part of that is normal. I would be surprised if someone told me that they weren't tired. And I think part of it is just being discharged and that effort to learn, because your brain's tired, you're physically tired. You may have side effects from the medications. You're going home, you look around your house, you think should be doing something. And I always stress that patients need to listen to their body, rest when they need to rest. And it may be that when you first go home, you need to sleep during the day. That's okay. We recommend, as in terms of exercise, no heavy lifting for the first 3 months. So no heavy weights. Walking is the best exercise you can do. Some people have an exercise bike at home. You can start slow. I don't recommend any abdominal exercises for the first 3 months because don't forget you're recovering from surgery, and that often takes 6 to 8 weeks. So we just wait that extra time to start exercising and anything strenuous. Patients ask about swimming, which we strongly encourage. It's wonderful. COVID's made that very difficult for people because a lot of the pools are not open. But as long as you don't have any open wounds, you don't have a subclavian line in or a peritoneal catheter, then there's really no reason in post-COVID times where you shouldn't be able to swim. It's great exercise. As far as fluid restrictions, we touched a little bit about that. I really encourage people to have at least 2 liters a day unless we've recommended otherwise. And that may be different for some people who have, some volume issues with fluid or cardiac issues, but that also will be discussed individually with patients. Patients who are diabetic, we encourage a diabetic diet. If you're not diabetic, healthy eating. So a Mediterranean diet, low carbohydrate, not necessarily high protein, but just a normal balanced diet. The dietitian will see you before you're discharged. You can have foods that are higher in potassium or that have potassium where you had to restrict it before. You don't need to do that now. You can bet we'll let you know if your potassium is elevated in your blood work. And we often have to ask people to cut back a little bit, but your new kidney should get rid of potassium properly in a normal functioning kidney. And so quite often that's not a problem.
Fantastic. And just in the last minute or so that we have you, I'm wondering if you could tell us a little bit about follow-up care. So what to expect with our medical appointments afterwards?
Yes, yes. So part of the discharge planning is that, so each of us, so we work as a team, as I explained before. So your team will consist of a physician, a nurse coordinator, and an admin assistant who may be listening to this session. And so she will go over before you're discharged and make sure that you, A, know how to get a hold of us, and B, when you need to come back. So a typical discharge pathway would be that you are required to do blood work twice a week at the hospital. And depending on the distance from the hospital, it may be that patients from out of town are staying close by in a hotel. Sometimes because it's necessary, sometimes because people choose to do that. So that's where the caregiver portion comes in and is very important to make sure that you, A, have somebody who can bring you into the hospital for blood work. Initially, we do want you to come in because we're changing levels of your medications sometimes quite frequently, and ensuring that we have blood work results the same day that it's done is really paramount. As soon as you can go to LifeLab, trust me, we encourage you to go to LifeLab. We don't want to bring you to the hospital any longer than you need to be. Visits typically are once a week for the first several weeks. And I say several because I don't want to be pinned down to one time, but we do try to typically it's weekly for the first 2 to 3 weeks. It may be longer, and it all depends on how you're doing.
Fantastic.
During COVID, we have, and sometimes in the first 100 days, patients have done very well and we don't need to physically see them. And we've been able to do virtual or phone visits. And that's been actually received quite well because patients are not traveling in, they're not paying the parking. And so that's kind of been a welcome thing when they're recuperating.
Mhm. Fantastic. That was a lot of information. Thank you so much for that. I know we'll have a lot more questions for you later. So thank you for that introduction to the care pathway. So I would love to turn it over to Sheena and ask you to tell us a little bit about your journey as a transplant patient. So, what was it like in hospital and what was it like at home?
Sure, thanks. I mean, I think everybody who's attending today is in a good position because I think part of my advice would be prepared, take in all the information you can before, because it can be a steep learning curve. So as I said in my bio, I'm one of 5 kids. 4 of us were born with polycystic kidneys, which my father also had. And I was the last of the 4 to be transplanted. So I had an advantage. I had a family that had talked about this. I had siblings that had been through it. And I had the knowledge that I would probably get there too. I was fortunate enough to be the oldest by far who needed a transplant. I mean, my one brother was transplanted 17 years ago at the age of 39. 3 little kids, they're a bit crazy, and he's doing really well. So I came into this with a really good feeling. I felt very empowered. Part of my journey, though, was that I did not have a clinical nephrologist who really supported that and really wanted me to be training for dialysis. To be clear, I've never been on dialysis. This was truly a preemptive transplant. I was not able to work at the same level. I've been a family physician for 31 years, and I also deliver obstetrical services. And I just couldn't do it at the same rate. So started the process. And the one thing I will say is I love the fact that certainly the TGH and actually other services as well. My sister was transplanted in Ottawa 2 weeks before I was transplanted in October. I love that the website had so much information so that even though I didn't feel particularly supported at that point by my clinical team, I was able to go on and see exactly what I needed to do. And the plan had always been, because we'd known about this for a long time, that my husband would potentially donate to me. Now, we have blood types that would be incompatible for him to donate directly to me. So we learned all about the paired living donor program. He was ultimately not accepted, which felt very threatening to me because I was terrified of asking people. But my sister-in-law stepped forward. And it's interesting to hear her rationale because she lives a very busy life. They had a whole ton of stuff going on, but we do have this genetic illness. We know that our children have a 50% chance of having it, and we already know who's got it. And she said to me, I need to show my kids this is what we need to do for each other. I mean, pretty powerful. So once we were accepted for transplant, it went pretty quickly. Hearing Theresa talk about medications, it really is something I would encourage you to prepare for and not just react to afterwards. I had an interview with the social worker at some point. She gave me a list of the potential medications. It also allowed me, I'm fortunate enough through my husband to have insurance, but it allowed me to go to the insurance with all of the information to say, am I covered or am I not? So that these are expensive drugs that allowed me before I went for it to understand this. I realized this was significant when I realized that my numbers were really moving quite quickly. I reached out to my younger sister to say, hey, we've kind of been on the same trajectory. Where are you? And what I realized is they were preparing her for transplant. And you know why? Because she thought she couldn't afford the drugs and she was scared to ask about it. So my younger sister was about to accept going on dialysis rather than a transplant because she couldn't afford the drugs. I mean, that was terrifying to me. So we sent out an email just to our family. And in fact, her partner stepped forward because I don't think he realized this was an option. So I do come from a very fortunate situation. So I had lots of time to kind of see this coming. And I also realized that some of the people here today might already be on dialysis, so it might not be preemptive, but I think there are some of the things that will be similar. So going into hospital, I was nervous and excited. I told you I was a family physician and I do inpatient work. I live about 2.5 hours north of Toronto, so I do kind of comprehensive care. So I've certainly taken care of patients. So it was definitely a new journey for me. I would say the care I received was stellar. There were a few things that I was surprised by. I was fortunate that I didn't have a central line. I did have lots of lines. And I would say those first 2 days, there were a lot of lines, there were a lot of alarms, and I was on a lot of prednisone, which I'd never been on before. So I've said to people, I felt like my brain was on fire. And at one point I thought, oh, I need to sleep. There's so much going on. I put in earphones, I put something over my eyes, and I realized it was not going on around me. It was going on in my head. And I felt a little crazy. But here's why I'm telling you this. It totally got better. It totally got better. But I thought there were a few nights where I thought, like, all these alarms, all these lines, and my head kind of really going was a little disturbing. Yeah, I would say the first 2 days, I would agree, Theresa. I didn't want to deal with anything, and I was needing stronger pain medication. But without getting into too much detail, I got constipated. I was not happy about that. So my advice is make sure your pain's well controlled. I actually did really well on Tylenol after the first 2 days, but I took it regularly. I didn't decide whether I felt like I needed it. I took it straight. And again, here's the thing. My younger sister said, Sheena, don't stop the Tylenol. You'll think you're okay, but you're not, and you'll regret it. Even my brother from 17 years ago said, Sheena, don't stop the Tylenol. So great advice. I followed it, and I'm so glad I did. I didn't need it. I probably followed it for a few weeks, and then I would kind of use it before I was going out for a walk or something. Yeah, be ready to manage the medications. Ironically, as my kidney function got worse, I was on less. So this was new to me. To Candace's point, if you're a phone person, find an app that you like or just set your own alarms. If you don't use your phone a lot, use your watch, set alarms. It's funny, even my kids will say, and they know this for a long time, when we were at big family gatherings, there would inevitably be an alarm that would go off and everyone would go, medication, because we just knew that you had to do it. I have an app on my phone. It's not a fabulous app, and I don't really want to pay for the paid part of it, but it works because it reminds me if I'm distracted that I need to take my drugs. In fact, again, my family will say, did you take your drugs? So your caregivers are important. Other stuff in hospital. I think I would encourage people, no matter what condition or where you're at in your journey right now, try to be in the best shape that you can be for where you're at. Just even having the ability to move independently around the bed is really important because your abdomen is not going to help you. I was impressed with the incision. Make sure you've got a pillow or something. If you have to cough or sneeze or you think you're going to vomit, it's terrifying. But if you're able to kind of push something into the incision, you can manage. So I would just preemptively have something available because I had some initial nausea, and when I would feel myself, I was more terrified about, I wasn't scared of vomiting. I was terrified about my abdomen. Nothing blows apart, but you feel like it's going to. I think my other advice would be post-op. I got walking maybe on day 3 or 4 with a walker and with help, like with somebody with me. I was shocked at how quickly my legs felt weak. Like I was in fairly good shape. I was shocked when I got out of bed that I felt like a little lamb, So be aware of that, be patient with it. And so take shorter walks, but take them more than once in a day. So be patient with your body, but keep going. Don't take it as an indication, I can't do this. Just do it for less time, but keep doing it because I found that really helpful. I got out at about 4.5 days, partly because I really wanted to. We live very far north, so we had to actually rent a place in Toronto, which was perfect. It was small, there wasn't a lot of work to do. I did sleep a lot at the beginning, and here's the other thing. I'm a front sleeper, so that played with my head a bit. I could not lie on my belly. I couldn't lie on either side at that point. My kidneys on my right, so over time, I could lie on my right side, and it took way longer to lie on my left side, and I can now lie any way I want, but it totally affected my sleep. So be aware of that you may need to adjust your sleeping, and I love sleep, so it was a bit of a problem. As I thought about this, one of the things I was asked was, what was the most surprising thing? And ironically, I think the most surprising thing was how great I felt after day 60. So not day 1, not day 10. But I as I got into that 3rd month, I just all of a sudden didn't feel post-operative anymore. I could start doing things, and I could start doing them comfortably. I've been so blessed not to have a lot of pain. In fairness, my donor had more pain issues than I did. But their surgery is just a little more invasive than mine was. And I felt guilty about that. I did. I felt guilty that she was suffering because of what she had done for me. Now she's fine now, she's back at work. I'm back at work. So I'm day 146, and I would say day 60 was a turnaround. And that was a big surprise for me because I felt like all of a sudden I felt way better. My head felt clearer, I would say almost immediately. Like my brain just did not feel that funky kind of feeling. I felt better filtered for sure. I think the last thing there were two things I wanted to say. One was about vaccines. I would say this was something that I did not think was particularly well managed in my case prior. It makes way more sense to get these vaccines before you get transplanted. So I don't know if it's your nephrology team or your primary care provider. You know, I'm a family doctor, so I knew this. So I went into my family doctor and I said, I want to get this, 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 and this. But I would really encourage that to be part of your conversation because like after the fact, it's, you know, you can certainly get vaccines, but your immune response will not be as good. My final piece of advice, accept people's help because it will make both of you feel better. So I'm happy to hear questions because I mean, there's lots of stuff. I don't know what people want or need to hear.
That's fantastic. Thank you. It's amazing to hear what you've been through and how great you feel now.
I do.
I know it's scary when you're going through the process, and I agree with you. One of the biggest shocks to me was how quickly I felt better than I've ever felt in a decade. I think within probably a week, I said to my, I think I can read a full book without forgetting what just happened. And that was really exciting for me.
Mhm.
One of my favorite things post-transplant, I'm a big foodie. I don't know if you can tell from my chipmunk cheeks too, but I love food. And so my thing was chili. And I think I ate chili for about 3 weeks straight because it had tomatoes and it had beans and it had beef in it. And I was so excited to eat some of the things that I hadn't been able to eat when I was on dialysis. And Theresa's laughing because I think she thinks, yep, that's a lot of people. So what was one of your most exciting things that you did post-transplant that perhaps you weren't quite able to do before you had your transplant?
So it's difficult. And I'm going to be honest, partly because of COVID.
Mm-hmm.
I mean,
Right.
I was fortunate to get in and get transplanted before Omicron, and then the world shut down.
Right.
So I've had a pretty isolated life.
Mm-hmm.
And that's probably curtailed me more than anything.
Right.
Not being able to see people, not being able to do what I want. What I do look forward to, though, there's still tons of snow here, but spring has come.
Yes.
And I look forward to getting into the garden and being able to work for longer because I would work in the garden. I'd like lie down. I remember when my mom saw that, she was visiting and I went to do something in the garden. I came in the house and she was like, you're usually out there for hours. So I am really looking forward to being able to do stuff like that without having to come in, lie down.
Mm-hmm.
Anyway, I do look forward to that.
That's great. My grandfather now calls me the Energizer Bunny. And he often says that all I needed was the extra batteries. And that was from my mother. So now he says, like, your batteries are back in and you've been going ever since. And so definitely the energy will come. It'll be interesting to hear what you harvest this year from that garden.
Looking forward to it. So that reminds me, though, I mean, my husband calls this my new little friend. My new little friend does stick out a bit, and that was a bit of it. So I had to kind of rethink how to dress. So I've worn a lot of sweatpants. Quite frankly, think about your underwear. Don't wear stuff that you're not going to want, stuff that kind of goes near your groin. So I hadn't thought about that, but yes, reconsider underwear and what that's going to look like. I am back to work now and I'm doing some in-person stuff. So I've had to rethink how I dress. I do not like shopping. So I have just adjusted clothes I already have, but honestly, from a practical point of view, that is something I had to do. And I hadn't really thought about that before. So make sure you got lots of comfortable clothing at the hospital, because that's what you're going to want to leave in.
That's great advice. Yeah. And interestingly enough, I had a friend who had recently had a C-section, a beautiful little baby, about 2 weeks prior to me going in for transplant. And she said to me, a lot of the maternity underwear for C-sections goes really high.
Yeah.
So she recommended purchasing some of those post C-section underwear briefs, which were lifesavers. So that's a strange connection to make, but
yeah, no, it totally makes
really
sense.
helped.
Totally makes
Yeah.
sense. And Theresa, you spoke about the stent removal. So here's the thing, it's over in minutes. It's so easy and it's so efficient.
Yes.
And so the other follow-up thing though, you know, you spoke about life labs. I live in Muskoka. It's a large geographical area. There are no life labs. I have to drive 94 kilometers to go to the lab.
Yeah.
So fortunately, I think that's going to change when you guys get your new EMR in the transplant clinic. But depending where you live, that you have to build that into your time because it's significant. Like I have to drive an hour. I have a 5-minute time in the lab, and then I'm driving an hour home. But
yes,
I think
there's definitely places that just simply do not have a life lab accessible, and then Dynacare is the option. But so having said that, we encourage life lab, but sometimes it's just, we don't want people to go to the ends of the earth to.
Right. And I think your new EMR is going to change that. So I think, which will make it easier for people without Dynacare.
That's fantastic. So thank you both for all of that information. It's fantastic to hear. And I think it's really exciting to listen to all of the, you know, ways that it improves our lives. Transplant definitely changed my life, and I know yours as well. And I'm wondering if any of the people here on our call have any questions for either Theresa or Sheena that maybe we haven't spoken about today. As I see, there's no questions in the chat, but even since it's a small group, if you feel comfortable, you can unmute yourself and ask the question if you like.
Can I give another good news point about medication?
That'd be great.
I remember the first day I was home, I sat down to take my medication. I had to take 17 pills. So now I routinely take 7 in the morning. I take 8 on the days where I have to take the Septra. It's much more manageable. I mean, some people pre-transplant might have lots of experience with medication. Some of these medications really smell. My Fortic has a very strong odor, so you get really good at just throwing them back and barely letting them touch your tongue. So it's a bit of a skill, but it can be acquired because, and my point is the number of medications certainly for me went down. Yes. I really didn't have any complications. I did have some nerve damage, which is totally getting better. My whole right thigh was very numb, but I could use the muscles, and that's absolutely improving. I can't believe over the last month how much better it is. And I didn't have to go on antivirals initially because my donor was CMV negative. But what happened with me, I get cold sores and I was getting them every week. So I am on antivirals now, and I have not had one since I went on them. So my point being, there can be complications, but there's often a solution or they get better. So that's maybe not been everybody's experience, but that's certainly been my experience.
Yes, I did. That actually brought me to one thing I did want to mention, to just emphasize that, you know, the other thing that I always tell people is, if you're having side effects, tell me, because you've had the transplant and you're taking the medications doesn't mean that you have to tolerate all of the side effects. If they're totally intolerable, you're not going to take the medication. That's just human nature. So a lot of times we can make some changes and make it better. That was one thing, because some people are just hesitant to bring it up because they think that that's the way it's supposed to be. The second thing is I really wanted to emphasize as well, when people go home, to really make the connection again with a few people. One being the family doctor, because many times patients are on dialysis for many years, and the dialysis unit tends to be that primary caregiver. So patients have lost touch with the family doctor, and it's key post-transplant to have that connection with a family doctor. Not every issue that comes up after the transplant, as far as in terms of health, needs to be addressed by the transplant team. And so we really encourage people. And one of the primary things that I try to emphasize is general population cancer screening. We are not doing that necessarily in the transplant, and that should not go by the wayside. So for example, mammogram and prostate checks and colonoscopy. And so it's very important to just make sure that they have that connection, to reach out to the family doctor. We'll send all of the information and for them to make an appointment. And the other thing is they will continue to follow up with all of the other physicians that they previously consulted with, whether it's the cardiologist or the endocrinologist. So some of the things that they should do in those first few weeks of getting home is just make sure that they have those follow-up appointments.
Fantastic. I know one thing as well, listening to your story, Sheena, and myself as well, I was very lucky to have a family that was advocating on my behalf, as well as, your family was very supportive, and friends. And I know sometimes as a patient, it can be very difficult for us to both discuss our disease, potentially what we're going through if we're on dialysis. Sometimes we just don't feel good enough to think about what we're going through. And so having somebody that can be your advocate and advocate for you, whether that is in medical appointments to listen to what the doctor's saying, or, to bring questions forward. But then also when we're talking about transplant, to have an advocate who can either be your donor, as my mom was, and she tried to advocate to get that process moving quickly, or to have an advocate to help you find a donor as well. I know not everybody has somebody who can step forward, but finding somebody who would be willing to help you find that donor is a great help, whether they support you through telling your story and helping to write down that story, potentially, sharing that with your small circle, and then, your extended circles, whether that's your church group or your sports activities that you're part of, your community groups, and then also even farther reach if you're comfortable on social media, having somebody advocate for you. So that was really helpful in my journey, to have those support people in place to help me through all of my appointments and, all of the potential grief that you go through about, thinking about your prior life before dialysis or before transplant, and, being excited for your new normal post-transplant, about what that's going to look like. So I'd like to maybe end with you, Sheena, before we have some closing remarks, just about what your why was. Why did you want to transplant? And what that why was that kept you going? Because I know through my experience being a young person, dialysis didn't fit with my lifestyle, and transplant gave me the opportunity to feel extremely healthy and be able to reach different milestones in my life that I really wanted to accomplish. One of them including, we had our first child in February, so I didn't think that was possible with my kidney disease, but because of transplant, we have a healthy baby girl who just turned 1. So she's my big why, to stay healthy and to continue move forward. And I'm wondering what your why was to have a transplant.
Well, I really like my work. I really like my family. And I'm going to feel guilty. I wanted to continue to enjoy a high quality of life. And here's the new thing for me. I'm going to get old. I mean, I grew up in a family where, I mean, my dad died at 53. He had a devastating stroke at 47 and never worked again. My uncles died in their 40s. So early in my life, I kind of thought, okay, it's not going to be that long, so I'm going to do everything I can. I just had this sense that I wanted to do everything. And I guess as I went along in life, I thought, I've still got a lot to give this world. And I'd like to be able to do that. And so the other thing I had is, and if I need to go on dialysis, and I will work to accept that with grace.
Mhm.
But I know that that would take my life in a totally different direction.
Mhm.
And I knew that this would offer me just like a new beginning. And so I'm 60 years old with a new beginning. So now I have to think about, oh my goodness, I am actually going to get old.
That's
So
fantastic.
I'll try and do it gracefully.
That's amazing. Thank you. So both of you, thank you so much for sharing all of your knowledge and your journey, both on both sides of the fence as patient and practitioners. I can see both of you have so much joy in what you do, and you know what transplant has done for you, Sheena, and what your career in transplant is, Theresa. For everybody listening today, we'll have this recording available on our Center for Living Organ Donation YouTube channel. We have some links as well in our UHN resource library. So there are different documents like Coping with Transplant, which discusses a lot of the things post-transplant that you can prepare yourself for. There is a manual about transplant that you can take a look at. There's a lot of great resources on that website that, you know, talk about the surgery and the medication and what to expect pre and post transplant. We also have some really great education series. So weekly we have patient education information. So there's living kidney donation, finding a living donor, financial resources for living donors. And these happen weekly. So you can find all of those on Eventbrite, as well as our website. And then we also have monthly topical webinar series. So we have Writing Your Transplant Story Wednesdays. That will start on April 27th, and that'll be a 6-week course, which will go through helping you write your transplant story for waitlisted and recently transplanted patients, and as well as caregivers. It is free. You can register at GiveLifeUHN.eventbrite.ca. And that's going to be a wonderful series. And then also for any information that you're looking for, you can always follow us on social media at GiveLifeUHN. And there's wonderful stories on there about patient experiences and information about our events and our wonderful guests that we have joining us. So thank you everybody for joining us today. Thank you, Theresa. Thank you, Sheena. We really appreciate all of your knowledge and being a part of this. And have a wonderful day, everyone.
Thank you, Candace.
Thank you.